Thank you, sir. So, just to start off with, I'd like to express my gratitude to the General Medicine Department and the whole organizing team for inviting me to present this particular topic today. It's an honor to be presenting in front of my teachers and my colleagues. As our respected chairpersons already said, this is a very, very common issue, most of the times kind of brushed under the table, as almost every ultrasound report says mild fatty liver. But the intention of this particular presentation, unlike Vasant sir's presentation that had a lot of exciting scenarios, this is something that is 100% silent. There are no clinical findings, there is no history, there is absolutely no way to really know it's there except for really getting into a few tests, and obviously if they have a background of metabolic syndrome. The intention of the talk today is to present a few real statistics and essentially scare the living daylights out of everybody here, so that hopefully we will follow the protocols and actually screen the patients that come with this ever so common mild fatty liver ultrasound report. So I think this is something that almost everybody has seen now. I think especially the Gastro Society likes to change the 5-letter terminology for fatty liver every couple of years. So now the latest one is metabolic dysfunction associated steatotic liver disease. And this is actually an important change to note, because fatty liver, as I already mentioned, keeps undergoing changes in its basic definition, and this over time has essentially allowed everyone to become very complacent with what it actually is, what is serious and what is not serious. So up till now, this NAFLD, non-alcoholic fatty liver disease, was diagnosed by excluding everything: hepatitis B, hepatitis C, any amount of alcohol intake, essentially any other cause of chronic liver disease. So essentially, if they have no other cause, not even a drug potentially causing altered LFTs, you call it NAFLD. The concept of metabolic dysfunction associated fatty liver disease is that we have to understand that most of the time the liver is hit by multiple things at the same time. Alcoholism, it need not be, a more than 60 grams in females or 80 grams in males. Even most people take, a drink on the weekend. That amount of alcohol may be there. They may have diabetes, they may have metabolic syndrome, and they also have a significant underlying steatosis. So everything hits together. They may also be on statins. Statins may be causing some amount of drug-induced altered liver functions. So in the concept of MASLD, or metabolism-associated fatty liver disease, what we do is it's a very simple diagnostic algorithm. Does a patient have biochemical or imaging related steatosis of the liver, which includes our mild fatty liver that we see on an ultrasound? If there is that particular picture, then we have inclusion criteria. So is there obesity, overweight or obesity, any type of metabolic syndrome, whether it be diabetes, hypertension, etc. And even if they have hepatitis B or hepatitis C, if it's controlled disease, that is also considered in MASLD. And this is important because now there are treatments, therapeutic treatments for fatty liver disease. And a patient that has chronic hepatitis B may also require to be given Bilipsa or Saroglitazar, may also be required to be given other therapeutic interventions for their altered LFTs or altered fibroscan. So this is one important conceptual change that is included in this change in terminology. So this is essentially the definition of fatty liver, where hepatic steatosis in adults or children, although in children there are slight differences in this definition for metabolic syndrome and fatty liver as well. But in adults, either by imaging by blood or biomarkers, which we will discuss subsequently, and by liver histology, the importance of which is slowly diminishing. Now we use non-invasive methods. So if either of these are positive, imaging or blood biomarkers, if a patient is overweight, in Asia, in our context, a BMI of more than 23, they are automatically termed as MASLD. If they are diabetic, again, automatically termed as MASLD. If they are lean, normal weight and not a diabetic, then we request for at least 2 metabolic syndrome risk factors, which are the same risk factors that follow our metabolic syndrome definitions. So this is essentially how you diagnose somebody or label a person with fatty liver disease. So this is, I'll just very quickly run through it, especially for the postgraduates here. So if we look at this particular patient, normally we would say that he does not have MASLD because there is ethanol intake of 50 grams per week or per day. So, and his HbA1c is 8.2. Again, we would say he's not, he's excluded from the NAFLD criteria. But as far as the MASLD criteria is concerned, he is definitely a metabolism associated fatty liver. Again, we take this particular patient. In this case, he has he's a chronic hepatitis B patient, but his HBV DNA is undetected. On the basis of that alone, we would have excluded him from any criteria of fatty liver, but again in the MASLD criteria, he is included. Again, we take a case of a 51-year-old male, hypertension, hypertriglyceridemia. USG is not done, but his fatty liver index is 90. Again, he is included just because he has a fatty liver index of 90 and he's got metabolic syndrome criteria. So it's a much more expanded view of which patients fall under this particular diagnosis. The only problem with this MASLD diagnosis is those patients with lean NASH. Those lean individuals who still end up having altered fibroscan and LFTs, they unfortunately can be missed in this particular diagnosis. So essentially there needs to be some amount of flexibility on behalf of the physician when we go through all the reports and diagnose a case of MASLD. And why is this important? It's actually quite frightening. There was a large Trivandrum community-based study which showed that 49.8% of our Kerala population has moderate to severe fatty liver. Not fibrosis, but fatty liver. And we already know 1 in 3 patients are diabetic, 1 in 3 people in our population are diabetic, and fatty liver is even more prevalent than that, especially considering obesity in our population, rice eating, high carbohydrate diet. We all fall into this category. So it's something that we need to probably spend a little bit more time, especially this is so important as in this particular context of physicians. Actually, the screening comes from there. The patients that end up reaching super specialists are always going to be less. And why this presentation was termed as masked is essentially because unfortunately you will not find it unless you actually look. And a significant number of patients, we are all familiar with the fatty liver to fatty hepatitis to fatty fibrosis to cirrhosis, but it doesn't always go in that order. And a majority of patients will have normal LFTs even though they have advanced fibrosis. So LFTs alone as a screening modality, again, we miss out on patients with advanced disease. As sir already mentioned, most of us even now ignore the mild fatty liver, and in high risk groups the incidence of advanced steatosis is up to 60 to 70%. As we mentioned before, even when we look at fatty liver in our own context, not all of them are obese. You have very obese patients with absolutely no fatty liver. You also have very lean patients with fatty liver. So there are different phenotypes, and this probably stems from the fact that there is a significant heritability in this particular condition. In multiple studies done showed about 27 to 30% of patients have genes that predispose them to fatty liver, to predispose them to early progression to cirrhosis. So this is probably another thing that may potentially be higher in our country, although I don't think we have had enough large studies. Given that almost all population-based studies for fatty liver in India show an incidence much higher, a prevalence much higher than the Western world. So it's not, as we all know, fatty liver, the liver is the largest metabolic organ in the body. It cannot possibly be organ specific. It is a systemic condition and it causes so many other extra hepatic manifestations, including higher risk of coronary vascular, cerebrovascular disease, higher incidence of chronic kidney disease. In patients with chronic kidney disease, they have a higher chance of moving into dialysis. There are multiple malignancies that these patients are at a higher risk for, including colorectal cancer, esophagus, stomach, pancreas, as well as non-GI malignancies, including kidney, especially in men, as well as breast in women. So it's just that right now it might be because we are gastroenterologists or hepatologists, but there is this whole chicken and egg story as to whether does fatty liver actually come from metabolic syndrome, which is what is currently taught, or is it actually reverse, given that the liver is the largest metabolic organ? Is fatty liver the predisposer that actually leads to insulin resistance and leads to the whole spectrum of metabolic disorder? That's something that is still up to debate. So again, this was already briefly mentioned, but fatty liver in itself leads to fatty hepatitis, fibrosis, and HCC. But HCC can happen in fatty liver even if you don't go through the rest of that spectrum. In fact, if you really look at the numbers, it's a little frightening, especially when you remember that 50% of our population has significant steatosis. Around 3% of the population, the MASLD population, will convert to cirrhosis per year. And of that, 0.3 to 2.6% will move into HCC. So these are big statistics when you look at the number of fatty liver patients in our population. Coronary vascular disease, or CAD, basically the studies have shown that where there are higher incidence of CAD, those are the populations where you do have higher incidence of MASLD as well. CKD, as I mentioned before, in patients with, obviously at that time they had used the NAFLD criteria, not the MASLD. Those studies are only going to be probably published over the next 5 to 10 years. But in patients with NAFLD, they have a much faster and higher rate of conversion to dialysis compared to patients who don't have NAFLD. Obviously, there is a lot of overlap here because metabolic syndrome comprises of so many different things, but it's all interrelated. So coming to the all-important question of who to screen and how. So risk-based case finding rather than population screening is probably more practical. So diabetics, obesity, that is anybody with a BMI more than 23 in our country, metabolic syndrome, dyslipidemia, OSA, PCOD, any family history of cirrhosis, all these patients should be screened. Now, obviously, we would say send everybody for a fibroscan, but that's not practical, and all major guidelines, including the American Association for Study of Liver Disease, European associations, and Asian Pacific, everyone still advises to use a very simple daily metric of FIB-4 score. I'm sure most of you would have heard of that already. The FIB-4 score is a basic calculation only with labs that are used that we check every day. Age into AST over platelet count by the square root of ALT. So it's a calculator, like our MELD score. It's a calculator, but it is extremely useful if you are in a smaller clinic or you're even doing a home practice. Since these are blood tests that we do routinely, getting a FIB4 score is still found to be the most effective way to have an initial screening. The concept is that if your FIB4 score is less than 1.3, you don't need to send them for ultrasounds and for fibroscans unless they have a very high risk factor of another kind. If they have a higher FIB4 score, they must be sent for a fibroscan along. Ultrasound is not even considered in the further evaluation or follow-up of fatty liver patients because it is too subjective. There is no objectivity to the ultrasound scores. Anyone with an intermediate or high risk has to undergo an elastography, ideally fibroscan, which is a vibration-controlled transient elastography, or some of the other second-line non-invasive tests which at this point today are not readily available in India. Some of them are this enhanced liver fibrosis. I think it's just coming out here. This is actually a blood test. It's a test that measures 3 direct markers of fibrosis. This includes hyaluronic acid, procholinergen 3, amino terminal peptide P3NP, and then tissue inhibitor of matrix metalloproteinase, so TIMP1. This is like a blood test panel. Most of the tests come in like 20 minutes. It spits it out like an ABG, and it calculates the score automatically. It's a little expensive. It's only coming out in few hospitals have it so far. But the advantage of this particular test is it's not only for fatty liver. It tests the process of fibrosis. So it can be used in hepatitis B, it can be used in alcoholic cirrhosis, it can be used in any kind of liver disease. But in Western guidelines, this is very much part of the algorithm. That's why I've shown it. But only 3 FDA approved drugs. Essentially, none of them have a very good effect either, studies wise. But that's all that is approved right now. The age-old misconception about ursodeoxycholic acid. There is no role for Udiliv at all in patients with fatty liver. Other approaches being metformin and simvastatin, more for diabetes and dyslipidemia than actually for improving the liver function. This is the same, these are all I just put this up to show that you really need a multidisciplinary approach to the treatment of fatty liver, where you need cardiologists, obviously the primary care physician, then cardiologist, gastroenterologist, nutritionist, and then even some amount of physical medicine, physiotherapy, etc. So we already went through the percentages and diet details. There's a lot of studies on these intermittent fasting, which is now found to be not beneficial in fatty liver disease. Mediterranean diet is still what is prescribed in all guidelines. The benefit of the rest are not necessarily proven. This is the most important question asked by every single patient when we tell them they have fatty liver. Can we take our quota? Essentially, there is no safe limit for alcohol in fatty liver disease. That's the sad reality, especially since everything is synergistic. Obesity, our diet, alcohol, it's all additive. So essentially, the unfortunate answer is it has to be a hard stop. So diabetes, I don't need to go into any of the details on diabetes, hypertension and dyslipidemia treatment. I'm sure each one of you knows this much better than myself. The only thing, a few things to consider here is that any patient, the moment they hit advanced fibrosis, it is ideal to start them on some form of insulin, because OHAs alone are thought to be inferior. Also, to just keep in mind that the HbA1c below 8 can be a high risk of hypoglycemia for patients with advanced fibrosis. So actually we err on the side of a higher HbA1c in diabetes management. Dyslipidemia, again, there is this endless controversy about statins. Technically, statins do not worsen fatty liver disease. It is just the biochemical change in SGOT-PT. That being said, most cardiologists will stop statins when the LFTs begin to alter. I think bariatric surgery and transplant, these are for more of advanced cirrhosis. ANA positivity, that's again, I already mentioned, because autoimmune hepatitis can be a masquerader. ANA will be positive in many patients, and this is often just an epiphenomenon, and we don't consider that as significant unless other biochemical markers are also abnormal. If we have an elevated total IgG, serum globulins are elevated, and any of the autoimmune hepatitis panel is positive, then we consider the patient for a liver biopsy. Another finding that is very common is these patients have very high ferritin. Actually, hemochromatosis is less common in our population, and high ferritin is most often just a false positive marker for hemochromatosis. We do not need to take them in for HFE gene mutation each time we find that. UDCA has no role in NAFLD. And just a word on saroglitazar, because that's the new magic drug for fatty liver, especially in our part of the world. Essentially, it's a drug discovered in India. It is a PPAR alpha and gamma agonist, and it is it's been a phenomenal drug when it comes to improving steatosis, although its role in fibrosis is still under studies. Unfortunately, though, this has not yet been FDA approved. There's probably a lot of political and whatever issues behind it. It is not a Western made drug, but in our area, we use this as the standard of care in any patient with fibrosis. If they have advanced steatosis or fibrosis, they are given 4 milligrams of Bilipsa or Lipaglyn. These are the only 2 drugs available, and the company is marketing it. We give 4 milligrams once a day. It should be given for at least 6 months before retesting FibroScan, because it takes time for the fatty liver to actually change. Many times we see people giving it for just 3 months, they see LFTs normalize and they stop it. The gold standard is it must be given for up to a year, and the retesting after starting the drug ideally should be only after 6 months. We do check LFTs after 3 months. The reason is because if they are raising even further, we have to think of autoimmune hepatitis, or obviously if the patient is continuing alcohol or there is some other confounding factor. Other drugs, obeticholic acid had come out as a big anti-fibrosis drug, but that has actually been now taken out of the market because there were a lot of other complications that came up in phase 4 trials. So the role of obeticholic acid in fibrosis is now no longer there. There are so many other drugs that have come out. Unfortunately, none of them have so far been able to show a significant improvement, so much to actually get into the guidelines. So it's an exciting field in hepatology because we are still trying to understand it. However, that being said, we have a long way to go. Essentially, I think as an ending slide, as physicians, our medical community, it's important for us to keep collecting data on fatty liver because this is something that is still underreported. There is a need for us to see that report of fatty liver as something significant, do a FIB4 and actually send any patient with a FIB4 more than 1.3 for a fibroscan because it can make remarkable difference in the long-term liver health of these patients. And with that, I'll end. Thank you for your patient listening.